soon, to take it off the subject that's making me cry, how soon can you start trying for a baby after chemo?
That was going to be my next question.
Well, you know.
So, can you just ask, just stay back a bit. Either come on camera or don't, alright? Make your mind up. But no, very importantly, so how trying to, like, fertility is a big issue, and if you are fertile and are thinking about a child and things, because that does happen. I think a lot of people, and fertility is something that we could open up and go down a massive thing, but people assume that after you've had treatment for cancer you're definitely not fertile.
Which is not the case.
Not the case. And so what do you, like, what is the thing?
Well, hopefully people who are going into cancer treatment will have had that conversation with their consultant, clinical nurse specialist, about what is the impact on my fertility with this treatment. And frequently, for people who are younger, we will, if there are two treatments that will treat the disease equally well, we will opt for the regimen that is fertility sparing, because we know that people want to have, or very likely want to have, children in the future. So we will try to preserve fertility where we can. It's not always possible, but certainly should be having that conversation of, is my fertility going to be impaired? And if the answer is no, then having a conversation obviously around contraception during treatment. But at the end of treatment, I think it's a case of going back to your consultant or to your clinical nurse specialist and saying, what's your advice at this point? Is now a good time? Is it safe? Is it okay for me to start looking to having a baby at this point? So that's if you've got your fertility. If you haven't maintained fertility, then and hopefully things might have been put in place for like sperm banking or embryo preservation post-treatment. My understanding, and I don't work in this field, so forgive me if I'm not 100% accurate, but my understanding is that patients should be 2 years post-treatment before they can be referred for IVF. So that's 2 years post-treatment. That's last treatment. That's not initial cancer treatment. So if somebody has 6 months of chemotherapy and then has a year of no disease and then relapses and has another 3 months of chemotherapy, the clock doesn't start ticking till the end of that 3 months of chemotherapy. So it's the last treatment. So again, a conversation worth having with your clinical nurse specialist or consultant.
We were talking about earlier, I was joking with Jemima that my sperm is in Hammersmith, so that hopefully, Jill, you're looking after that, or down the road.
Absolutely.
It's not in your department.
It's not technically my responsibility.
In your freezer there. But yeah, that's a big thing for both male and females. I think that, like, you're looking at thinking about the decisions, and that sometimes they're decisions like about your fertility that you make when you're kind of not thinking about it as well. It might not be. So I was 19 going on 20, and like the thought of not being fertile at that age, I just kind of went along. Like, my response to it was, okay, fine, I'll just do that just for the sake of it. And it now I'm 28, and it's the reality that now it's actually a question. Now it's a question. Now it's a thing to be thinking about. And you go, well, actually, what decision did I make nearly 8 years ago now? And how? And
you're asked to make these decisions in almost crisis time, aren't you? You know, we've got to start. This is your diagnosis. We need to give you treatment. So what do you want to do? No rush to make a decision. But if you could tell us by the end of the day, we'll
and if you could just go down into the little cupboard just down there, please. Because of course it's not done in the cupboard. That's not exactly.
Depends where you go. But that, and you know, of course, why wouldn't you want to go off and do that when you've just been told you've got cancer? You know, that really puts you in the mood, doesn't it? To go into the cupboard and sure.
Yes. Thank you. So let's. Because that was a question from the network as well, was around thinking about when you can have children after chemotherapy, and like we're looking at lots of questions coming in from the network. So if you have got any others that you'd like to throw in, please do. Let's talk about we've touched on talking with your partner and things, and how important it is to do so throughout it, and we're mentioning about new relationships as well, but is there a way that you can? It's a question that I've written down, and I kind of know the answer to myself, but I'm going to pose it anyway.
You can answer it.
Is like well, maybe not. I'll throw it to you. Is there a way that you just don't tell people you had cancer? Is that okay? Is that... I don't know. Can you not tell someone you have had cancer?
I guess it's your information, and it's up to you who you want to share it with.
Yeah, I think that's...
I suspect if you want it to be a long-lasting, deep and meaningful relationship, holding something like that back might be a bit of an issue further down the line, but that's an individual's choice.
Yes, yeah. And when... just looking through these questions, and I mean, Jemima's just been like, you've literally asked about 3 of these questions that I've written down, which is really unfortunate because now I'm...
No, it's running out.
I've got some more questions.
You've got a question?
Yeah, I think the one about physical...
Well, I'm going on to those.
Oh, fine.
But no, you go and ask it now.
And there's no more.
Is it? Okay, well that's alright then. I'm just going to put a tick on that because we've talked about the importance of talking to your partner, and I mean, we can't, it's... Talking to clinical nurse specialist is one way, and also to your partner, being open to this conversation that things are happening around sex and cancer is, I don't know, if we leave with anything today, that seems to be the number one thing.
And I know, as you said, we've spoken a lot about it, and often it's, speak to someone that you're comfortable with. If you've got a good relationship, it doesn't have to be the clinical nurse specialist or the consultant. If there's one of the other doctors or one of the other nurses that you have a good relationship with, ask someone that you're comfortable with.
Yeah.
And if you feel that you just don't know how to broach the subject, you can always ask your clinical nurse specialist if you can have, and it's very hot topic at the moment, so I'm sure people out there know what we mean when we say an H&A, which we abbreviate, which is either a health needs assessment or a holistic needs assessment. And if people want more information, you go onto somebody like Macmillan website, because there's information. There's a huge amount of information, and these are essentially tick boxes where patients can tick all the things that they might have that are concerning them. So if you don't know how to broach the subject of sex, and you don't want to look, that after all this treatment you're going through, that's the only thing that you want to talk about, ask for a health needs assessment with your CNS, and it's one of the things you can tick on the box. So it's easier to introduce it when maybe you're ticking it on a piece of paper and giving it to your CNS to say there are some things that I'd like to tick and to discuss, and you can tick it, which is sometimes an easier way into the subject than just saying, I'd like to talk to you about sex.
Yes, it's so difficult to bring it up in...
Yes, but it's an easier way to bring up the topic.
Yes, to find it, and that's, allows us to bring out what perhaps we're feeling a little bit more.
Yes.
Can I go to some specifics?
Of course you can.
Specifics, that's a hard one to say. So we've discussed about dryness, vaginal dryness and things, and we've discussed about lubrication and different options about talking to clinical nurse specialists around that. And I guess on the other side, erectile dysfunction, and is that, how would a man approach that? And is it something to go to CNS? Is that?
Sure, absolutely. Obviously, depending on what your cancer is, for example, if it's urology, prostate cancers, which is not my area, but these men, a lot of these men are having surgery or radiotherapy, and it's one of the things that they are counselled about, that there's always a risk post-treatment of erectile dysfunction. But I think, so hopefully that subject's been discussed, so people are aware and they have information. Yeah. But actually, even if physically there's not an impact from the treatment, the anxiety of it happening can have the same effect, really. And again, it comes back down to talking to people and discussing it with their healthcare professional. It's common, and sometimes it's difficult to really get to the nitty-gritty of, is it purely physical, or is there an emotional element attached to it as well? But there is help out there, and whether that's help going to a urologist or for psychosexual counselling, there is help out there, and it shouldn't be ignored. And I don't think you should accept that, well, that's probably just all part and parcel of the treatment, and I won't say anything about it, because there is probably something that can be done.
Yes.
Whether that's taking medication or using appliances, and again, I'm not an expert, but people who work in that field will have that information and would be happy to discuss it.
And that obviously stretches to soreness as well, and thoughts of maybe infections around the penis and things. Is that are there things that you can do yourself, or is it just a case of going and speaking to somebody?
I think it's always important to rule out a physical cause for something. So if people are having erectile dysfunction and they've got pain around the penis, I think speak to somebody and rule out, for example, if there's any infection. Because sometimes people accept that this is, well, it's just one of the side effects of my treatment and I just have to live with that. Actually, sometimes it's something very simple. And if it's infection, it could be that 5 days of antibiotics or something can clear it up and the problem's resolved. But if you don't discuss it, people don't know, and it can't be dealt with. So always discuss it, because yes, there are sometimes very simple things. It might be using a lubricant to relieve dryness. That can be the solution. And
keeping yourself clean, I think, is, and I mean that goes beside itself always, right? Is just to make sure that everything's clean and regular cleaning. Like for gentlemen, that can be something that is put to the side, I think, sometimes, and it's such an important part of hygiene as well.
Absolutely.
And around so when you are, let's talk hygiene as well. Around things like anal sex as well. If you've got a low immune system and you're wanting to have anal sex, is there way, like, is that are you able to? Is there hygienic ways to do that? Like, or is it, what?
I guess my advice would be if your immune system is suppressed to any extent, my advice would be to use a condom to limit the risk of infection, whatever sex you're having.
Yes, okay.
And again, it's worth talking to professionals because you should be aware of what your blood counts are. I think that's fairly crucial. People would be needing to know what the white count is, to know what the risk of infection is, and also what the platelet count is. Because if there's a low platelet count, there's more risk of bleeding, particularly if you're having anal sex. So just really practical things about knowing what the blood counts are and how safe, or at this point in treatment, maybe it's not recommended because there's too much of a risk of infection or bleeding. And again, that comes back down to getting the information.
Yes. Wow. Okay. Thank you. And you mentioned just very quickly there about contraception, but are there alternatives to condoms? Some people don't like using condoms. Some women won't able to use the pill because of certain drugs. Are there alternatives, things that can be used?
I'm not an expert on that, and I don't deal with that type of cancer where there's hormones related, like breast cancer. I would talk to your clinical nurse specialist. But again, it's also about having information about what blood counts are, because if you're using a coil or a cap, something like that that has to be inserted, but has to remain in, then there's an increased risk of infection.
Right.
So it might be appropriate at some points within the treatment cycle, but not at all. And I think that's a conversation that people need to have with their clinical nurse specialist. You can't give out blanket information on it because it varies so much between individual treatment.
Great. Well, I'm learning so much.
You're going to be a clinical nurse specialist till the end of this.
I don't know if I can handle it. I don't know if, so I think we've covered about contraception and like the different things that you can do once you know it. But the important thing again is just to speak to your clinical nurse specialist. It's to know about your blood counts as well when you're thinking about any type of sex, and really I think that's summing up everything that we were trying to talk about. Really, is making sure that you know what you're facing up to and things, and having conversations around it. Jemima, have we got anything else before we?
I think one thing that so you can get vaginal GVHD, and a lot of women might not know about that, and a lot of people might not know that as being a side effect.
I don't know.
So I was wondering if you're happy to talk about possible ways that you could explore that.
I mean, GVHD,
what does GVHD?
graft versus host disease,
Right.
is very specific to a small number of patients, and it's only for patients who have had allogeneic bone marrow or stem cell transplant. And it's essentially, very simply put, it's a reaction between donor cells and with the patient, a reaction between lymphocytes. Tends to come on and be kind of round about a year after transplant. Chronic GVHD is very difficult to manage, and patients are often not aware of it because they're not having sex. some women are not aware of it because until, for example, they go to have a smear test 6-12 months post-treatment because they haven't felt like having sex is uncomfortable, it's just not been top priority. Suddenly they're feeling better, they go along for a regular smear test to the GP, to the practice nurse, and they are unable to insert a speculum. And essentially it's just narrowing of the vagina, which you can get with treatment anyway, but with graft-versus-host disease on top, it can make it very narrow, and sex is, I was going to say very uncomfortable, but sometimes it's simply impossible, and that requires referral onto gynecology, where women can both can have dilators so that they can try to stretch the vagina again.
Wow.
But that's that doesn't happen with all cancer treatments. This is very specific to allogeneic stem cell transplant.
Can you do anything yourself to work out if that's...
I think just being aware of it, being aware that it's an issue, and having some understanding of what pre-treatment normal was. That's kind of key. And even if you're not aware of what's changed, your partner might be. Because sometimes, let's be honest, your partner spends more time down there than you might. So your partner might be the expert, on the business end, as it were.
Brilliant.
And just understanding that it can happen, and that things can be done about it, and don't just think, oh well, that's part and parcel of the treatment, I just have to live with that.
That's amazing. Thank you, Jill. And I think that last point really emphasises how unique we all respond to different sexual things when we're having cancer treatment, and about being aware that is the important thing, is that it is about how you respond to it, and we can give responses to things that might be going on, but it's only you are the only person who will know what is happening at that point, and therefore it is important about how important conversation is at that point, how important it is to have a conversation with your partner about how they might be feeling in response to what you've gone through, but also how you might be responding to what you've faced or are going through at this time. And it's really important to note what was happening before, and therefore what's happening during and after, and to look forward to go, well, what do we want to be happening down the line as well. So important to talk to your partners, but also to your clinical nurse specialists like Jill here, and it's really important that you talk to different people. You might even choose to talk to the wonderful people of Trekstock right here, where we have the email address which Jemima was holding up and has now put down, so I can't read, health@trekstock.com. Obviously there's plenty of different ways you can get in touch with Trekstock. If any of these things you would like to discuss them further, do drop Jemima and the team here a line. And I think what we're trying to look at today is the fact that sex is part of being a young person and being an older person as well, being a person in general. Sex with cancer is very difficult to talk about, but it's so important to talk about, and that's what we've been trying to do today. I hope you've enjoyed it, and I hope that it has perhaps sparked some thoughts and feelings that you might have, and if you'd like to drop us a line, do so. Thank you. Thanks, Jill.
Thank you.